Yeah, thanks everyone, and thanks for joining. Today I wanted to share my work on some modeling of the maximum price threshold of lenacapavir in South Africa, Western Kenya, and Zimbabwe. So as everyone on this call knows that despite substantial strides in the HIV epidemic and declining incidence globally and in sub-Saharan Africa, HIV is still disproportionately impacting sub-Saharan Africa and is still a leading cause of morbidity and mortality. And pre-exposure prophylaxis is a promising strategy to reduce HIV incidence. It can reduce acquisition of infection by up to 90% when used with high adherence. However, despite many efforts and availability in clinics, PrEP uptake has fallen far short of UNAIDS global targets, with just 10% of those with HIV risk indication in low and middle income countries accessing PrEP. And among those who do access PrEP, PrEP continuation rates are often suboptimal. About 50% of individuals drop out of care at each refill visit. And then further, PrEP adherence among those who are retained in care is not fully 100%, it's closer to 75%. So all of these issues kind of compromise the effectiveness of PrEP in combating the HIV epidemic. Some barriers that have been cited in terms of barriers to oral PrEP scale up are the burden of taking a pill daily, the stigma associated with taking drugs associated with HIV treatment, and then availability in clinics creating long wait times for the 3 monthly refills that are needed. So long-acting PrEP formulations show promise to overcome some of these barriers associated with daily PrEP use and increase coverage in sub-Saharan Africa and other priority areas. So both qualitative studies and discrete choice experiments find that there's a strong preference for long-acting PrEP over oral PrEP across groups in female sex workers, persons who inject drugs, and adolescent girls and young women, and the general population. So overall, it seems like there's going to be a high demand for long-acting products, and there is a preference for the longer duration products. So lenacapavir, or Len, is an injectable PrEP that's currently in phase 3 clinical trials. So it's projected, although we don't have primary data on effectiveness yet, it's projected to have a similar effectiveness as cabotegravir of 95% in preventing HIV acquisition. And CAB, for those of you who may not know, is the 2-monthly injection. However, the price threshold at which Len would be cost effective in sub-Saharan Africa is not certain. So our objective was to estimate the health impact and the maximum price threshold for Len under varying scale-up assumptions. So in order to inform policy deliberations with pharmaceutical companies about where the price should be set for Len in sub-Saharan Africa, which would depend on who's taking it and the demand and the volume, we conducted a modeling analysis across several countries to assess both the health impact, so HIV infections and HIV-related deaths and DALYs averted, and also the cost impact. So we used a cost effectiveness threshold of $500 per DALY averted, which is commonly used for economic evaluations in sub-Saharan Africa. So the countries we modeled and the regions are Western Kenya, South Africa, and Zimbabwe. So Western Kenya and Zimbabwe have lower HIV incidences with and prevalence, with Western Kenya being a little lower than Zimbabwe, and South Africa has a higher prevalence and incidence, and also a more resources and a likely a higher kind of cost threshold. So we used EMOD HIV, which is an agent-based HIV transmission model, and it's developed by the Institute for Disease Modeling, which is part of the Gates Foundation. So it's a model that has population demographics, disease progression of HIV, from acute infection all the way up to AIDS, and it simulates heterosexual HIV transmission. So individuals in the model form partnerships and then can transmit HIV to each other, and they can have different types of partnerships. So commercial partnerships, which are with sex workers, or longer or short-term partnerships. And the model also has the impact of intervention, so we can simulate the impact of ART and PrEP on these disease dynamics. So we individuals can test for HIV, and if they're positive, they have a rate of linking to care and then becoming virally suppressed and dropping out of care. And similarly for PrEP, we can simulate individuals linking and then dropping out and adhering to PrEP. And so in order to inform this model, we used data from Western Kenya and South Africa and Zimbabwe. So we used data on fertility, mortality, voluntary medical male circumcision, as well as health-seeking behavior, so HIV testing and linkage to ART. And then we calibrated the models. So we ensured that they kind of matched the HIV epidemic in terms of prevalence by age and sex, ART coverage, and then population size. And then we calibrated the model and used 100 parameter sets. So then we can kind of get a mean result and then a 95% model variability to give some range of uncertainty in our estimates. And this is just an example of the calibration. This is the model fit in the blue line is the mean model outputs, and then the gray lines are the range. And then the black dots and the error bars are the empiric data from Western Kenya. So this is the model fit in predicting HIV prevalence in Western Kenya over time. So in terms of oral PrEP assumptions, we used historical estimates of oral PrEP use from AVAC, and so that's they provide data on volume of PrEP distributed and who might be using PrEP from each country. And actually, Ingray provided some of those estimates for us, and he's on the call, so thank you. And so the oral PrEP it was assumed to be used, at least for Kenya. So oral PrEP was assumed to be used by women in the highest sexual risk category for 3 months, which is the average duration that PrEP is used across clinical trials. And we assumed that the volume of oral PrEP remains unchanged once LEN is introduced. And that's an assumption. So actually, many people might switch from oral PrEP to LEN once it's available. And we're hoping to conduct sensitivity analyses as well on that assumption. And we assumed that oral PrEP would scale up over the next several years and reach 3 times the current levels by 2027, equally distributed to men and women. But we also did a sensitivity analysis where we left oral PrEP at its current levels. For Lenacapavir, in terms of the assumptions in the model, we assumed 95% effectiveness for 6 months post injections, and then no effectiveness after the 6 months. So no kind of tail in terms of petering protection. And we didn't model the impact of Len on drug resistance. So preliminary studies show that there won't be a major impact, but there's not enough data to really fully understand that. We assumed that Len would be available for 10 years, so scaling up from 2026 to 2029 linearly, and then stopping at 2036. So we just artificially stopped Len provision in the model, but then we still continued running the model to assess the health and economic impacts of Len through 2060, just to understand the long-term benefits among those who were given Len. And we did a literature review to inform our cost assumptions. So we assumed a delivery cost for Len, including the injectable and the test and the infrastructure. And we assumed 10% of the cost of the product would be for demand generation. And we also included the costs of HIV illness averted. So by scaling up Len, we would have less people getting HIV, and therefore we would save money on ART, which the inputs are here in terms of the cost per year, and we would also potentially save money on the cost of illness for hospitalization among those who would have had HIV. And we used, as I mentioned, a cost effectiveness threshold of $500 per DALI averted, which is typical for sub-Saharan Africa. So in order to target Len to the population, we used the voice risk score, and that's a validated risk assessment tool developed by Jen Balkis and others at UW, and in order to predict HIV incidence among women in Africa. And we use this to prioritize PrEP provision. And so the risk score is calculated based on a sum of point values. So if someone is, or if a woman is under age 25, that's 2 points because there's a higher HIV incidence in that age group. Unmarried or not living with a partner, 2 points. Partner does not provide financial support, 1 point. Your primary partner has other partners, 2 points. Alcohol use and curable STIs were both 1 point, and HSV2 is 2 points. And you can see on the graph here that we have, as the risk score goes up in the cohort that they assessed, they did find a higher HIV incidence. And we don't have all of these factors in the model, so we don't model alcohol use or financial support, but we kind of, as best as we could, took this risk score and created a targeting to expand Len use in women with expanding degrees of HIV risk. So our first strategy was Len provision to female sex workers, and then individuals with or women with a voice score of greater than 5. And that would be 3 of any of the following categories: either 15 to 24, unmarried, have a sex partner who has other partners, which is something that we can see in the model, a medium sexual activity score. So individuals in the model are given a low, medium, and high sexual activity score, and we assume that those with the medium score might be that might serve as a proxy for other risk factors like curable STIs. And then the voice score of 3 was sexually active women with at least 2 of the above risk factors, and then 4 was at least 1 of the above risk factors, and then a voice score of 5 was just broad provision to sexually active women, regardless of other activities. And then we ran another scenario set, which was the above group plus men who are clients of female sex workers. And then a third scenario where we had men, we had all of the scenarios of women, plus we included men who have multiple partners. And so this is the results for our first scenario set for women only. And you can see on the x-axis is the percent of the adult population using Len, and then the HIV incidence reduction on the y-axis. And female sex workers are the smallest component of the population. So they're providing them Len is associated with small population coverage, but also the smallest reductions in HIV risk. And then it scales up to women with a voice score of 5, and then 3, and then the last orange dot is all sexually active women. And then if we assume Len provision to that category, we have over 15% of the population using Len, which is a pretty wide kind of upper bound. And then the price per threshold, or the per dose price threshold for Len under each of these scenarios is now shown on the right. So the highest price thresholds were sustained in South Africa. So and we can see a declining per dose price as we expand the risk profile. So in sex workers, the maximum cost is the highest, and it's kind of substantially higher, with 589 in South Africa, and then 23 and 39 in Western Kenya and Zimbabwe. And then it declines as we expand the risk categories. So it drops considerably from sex workers to all women with voice score of 5. That's $92 in South Africa, and then down to $5 in Zimbabwe. And then when we take that same scenario and add men who are clients of female sex workers, we get the effectiveness results on the left. And so the gray dots are the prior analysis that I just showed. And the black kind of line is the new scenario set with men. And we can see in South Africa, it's kind of on the line. So it might be efficient or similar efficiency to provide Len to men, but in Western Kenya and Zimbabwe, this whole scenario set was underneath the gray of the main analysis, which suggests it's kind of less efficient to include men who are clients of female sex workers kind of in these scenarios. So the cost per threshold or per dose across these categories does go down when you include men. So instead of $500 per dose in South Africa for sex workers, we're now seeing 112, and then 6 and 13 for Western Kenya. And then the impact of including men on the wider population cost thresholds is less impactful in terms of there is still a reduction, especially at the higher risk scores. But once you get down to a risk score of 3, 1, or the whole population, these numbers are really similar to the women only. And then we ran the third scenario set, which is women plus men who have concurrent partnerships. So these are men who would likely have a PrEP indication because they have 2 simultaneous partners. And we find in South Africa and Zimbabwe, the new black line is kind of above the gray line. So that indicates that it could be an efficient strategy in terms of HIV incidence reduction, balanced with the number of doses of Len, the number of people that are using Len in the population. In Western Kenya, it's below that gray line, so we're seeing less efficiency there. So it might be more impactful to scale up Len to women rather than men in Western Kenya. And the costs per dose are on the right. And they're similar, maybe a little more efficient than just the male clients of sex workers category, where there's a bigger reduction in price for the sex workers and the voice risk score of 5, and then less of an impact at wider coverages. And then we also did a scenario of increasing the time that Len is provided in the population. And so this, as a sensitivity analysis, we had 10 years of Len implementation on the left, and then we had 20 years of Len implementation on the right. And then when we add men to each of these scenarios for the 10-year implementation, there's not a huge added benefit of including men, just a little bit more efficient in South Africa and Zimbabwe. But when we look at a 20-year time horizon, if we were to include men for a longer time, it does become a more efficient strategy. And one of the reasons we think that might be happening is men are more likely to transmit to women. And so although they have a lower relative incidence of HIV, they transmit much more because they're more likely to have concurrent partnerships. So providing PrEP and providing long-acting PrEP to men might be a efficient scenario in a long enough time horizon when you can count those downstream infections averted. And then with a 20-year LEN implementation, as opposed to 10, the price per dose threshold is lower, and that's likely because HIV incidence is declining. So if you're using a longer, if you're assuming LEN implementation for a longer time horizon, it's going to be the later years are going to be in the context of a lower HIV incidence. So we could see it goes down, for example, for sex workers in South Africa from $87 to $73 for the same scenario when doubling the time that it's implemented. We also ran another scenario where we looked only at LEN provision to men. So this is only for all men with either that are clients of female sex workers or who have concurrent partnerships. And we see that in South Africa and Zimbabwe, the dots are kind of on the gray line, which means it is likely an efficient strategy. And then in Western Kenya, it's a little bit below. And these are the cost thresholds for men only. So this is a summary of our results. We overall find that on average, with greater LEN coverage and expanding voice scores, we have a drop in the maximum price threshold. So the highest by far is female sex workers only, if we were just to provide LEN in that group, which is unlikely because it's a pretty small group and it would have a low relative incidence reduction, although it's has the highest cost threshold. And then expanding out, the cost threshold declines. And then if we're planning on just providing LEN to all sexually active women or plus men, it goes down to $28 per dose in South Africa and $3 in Kenya and Zimbabwe. So overall, we find that the LEN price threshold is substantially higher in South Africa compared to Kenya and Zimbabwe. And this is assuming the same cost effectiveness threshold for all three countries. So $500 per dahlia averted. And this is a supply side threshold, which may not be universally the same across regions, especially since South Africa has a higher GDP and an economy compared to the other countries. So if using a higher cost threshold for South Africa, then they could sustain an even higher cost per dose of LEN. The LEN prices are highest for female sex workers, but this results in the lowest proportion of infections averted. So likely it would be a higher kind of coverage of the population that we would want to achieve with LEN. And the max cost declines with expanding population coverage. And when we assume LEN uptake among women with high HIV risk, like female sex workers or a voice score of higher than 5, then adding high-risk men will decrease the price considerably. But when we assume adding men to a coverage scenario of women with medium risk, the max price is similar when we include men. And interestingly, inclusion of men it was an efficient strategy in South Africa and Zimbabwe, but not in Kenya. And we think that this might be because of the high coverage of voluntary medical male circumcision in Kenya. So that kind of already protects men in Kenya in our model and in the country in terms of acquiring HIV. So when we include men in that scenario, it seems to be less efficient than in other countries with lower VMMC coverage. And then price thresholds were slightly lower with a 20-year rollout, likely due to the declining HIV incidence in later years. And then the role of men changed when looking at 20 years versus 10. So in South Africa and Zimbabwe, as I mentioned, expanding Len coverage to the highest risk men was efficient to the next highest risk women over 20 years. But in Nyanza, it remained less efficient. And so, and as I mentioned, this is likely because men are transmitting more to women, and that can be seen more with a longer implementation. And we did find that targeting only the highest risk men is also just as efficient as the highest risk or women with a voice score 5 in Kenya and Zimbabwe. So I would like to acknowledge all of the people that made this work possible, including the team at the University of Washington and NYU, who we collaborated with on this analysis, and also the folks from the Gates Foundation and the Institute for Disease Modeling that provides software support, and of course the funders, the Gates Foundation.